This is borrowed from the MA program, so Donna was nice enough to let us use this. It is a blood pressure arm, so if you're having trouble not knowing what you think you're supposed to hear, or those types of things, if you're having difficulty acing the blood pressure or thinking that you're hearing what you're hearing or not hearing, this machine, you can actually set it. All you have to do is turn it on. The power button is right here, and you can go up and down on the numbers. Right now it's set at 134/92. So you just pump it up like normal. You use the stethoscope like normal, and as you come down at 134, you should hear the first beat, and at 92, you should hear the last beat. So you can change it up. You can have a partner set a different number for you so that you can see if you can hear it. I would advise that you set it so you can see it first, so you know what it kind of sounds like, because it's kind of like a clicky. It doesn't sound exactly like a heartbeat. I mean, it's not super far off, but it doesn't sound exactly like what a human one sounds like. So that way that you know what this one specifically sounds like, so at least you can get used to hearing what you're hearing, the first, the last, anything in between, those types of things. So last year's class found this helpful. It's the first year that we had used it, and Donna was lovely and said that we could use it again this year. So it is here at your disposal. It will stay in the lab. It does not belong to us. Please treat it with extreme care. Make sure that you're putting it away, turning it off. It does just take batteries, so if it won't turn on, let me or the lab assistant know. Kalisha has plenty of batteries, so that's not an issue. If it runs out of batteries, it runs out of batteries. Donna doesn't know how long this set's been in it, so she has a couple, and her students are not using it right this moment. So any questions about that? If you're not having issues, you don't have to use it. It's just another tool if you're having difficulties. On that note, did Dr. Terry talk to you guys yesterday about her new mannequin?
No.
Okay. She has a brand new, it's very lifelike, it's really cool, tool in her room that we're going to be able to, I don't know if we'll be able to use it much this year because it's just been set up, so. But you guys may be able to help name it. So when the lab is open later today, I'm just gonna set this up here by the board. When the lab is open later today, her lab is open. Hopefully it'll be open later this afternoon, and we can go in and view her mannequin. She wants my class to come up with 2 names, because he has to be named. And her class is gonna come up with 2 names. She wants my class to come up with 2 names, or mine and Dr. Terry's classes, come up with 2 names. And then they're gonna put the 4 names on the Facebook page, and they're gonna let people vote on what her brand new machine is going to be named. For her students, they'll be able to do blood draws and all kinds of things. She's going to let us use it for pulses. Sometimes it's easier to find it on something like this and then get your places down and then look for them on a person. The nice thing is we're going to be able to set it to do auscultation, and then we can set them to have bad lung sounds. Again, it's not going to happen for you guys, unfortunately, or fortunately, whichever way you look at it. So I get you. But there's just going to be some things that I don't normally have the opportunity to let you guys see or hear or witness, because these mannequins can do all kinds of things, and she actually has a baby too. Yeah, he's pretty creepy. We can set it to have a seizure. This thing does these things do all kinds of things. They move, they're very lifelike, so, but she wants us to come up with 2 names. For the mannequin is a gentleman. You can actually zip the whole front of him off and replace him like with a pregnant lady. They're very, I mean, they're really cool things, and she won't be getting any more parts to him for a very long time, but, you know, she will even be able to set it up. I'm hoping that maybe by the end of our semester, she'll at least be able to set up the computer screen to look like an ICU monitor, so I can at least kind of show you guys, okay, well, this is what it's going to look like, this is the heart rate, this is the O2 sat, you know, so even that would be able to give you guys a leg up, something that I don't normally have an opportunity to actually show you. So her and I work really well together, and so she's, you know, she's like, what's mine is yours. So, you know, and my labs are on opposite days from hers. So like her students aren't in the lab today. So that works out real well, that if we were to want to, you know, use him for something or let me demonstrate something on him or let you guys feel pulses or pulses on the baby or, you know, anything like that, that we would be able to use that. So, but I think you need to see him before you start thinking of names, so we'll try to do that this afternoon. I'll see when she's available to open up the lab for us, so that we can hopefully go down there sometime this afternoon. So that's coming, but that is on loan. Hopefully by next year we'll just be able to go in and do the blood pressures. He has a sim pad, so I can sit right there and set the blood pressure and then tell you to take it, and I'll know what it's supposed to be versus what you hear. So, pretty cool. But, I mean, it's the same premise as that, it's just that you're setting it yourself. I'm still not going to use it for practicals, but, you know, at least will give us an idea of if you're hearing what you think you're hearing, and so it'll be a good practice tool. So, where you just...
I was going to ask if that was the baby doll
yeah.
that I saw.
Yeah, that was the baby. So... And the baby was a bonus. Nobody ordered the baby. Nobody knows where the baby came from. But it came with an intubation kit. It's got like like they can draw blood from it came with like fake umbilical cords and a meconium that you put in the mouth to be able to hear it. That thing is incredible. I'm like, I want to play with it.
It's creepy.
It is creepy.
Remember, Hunter?
It's like,
That's what I tapped you on the shoulder
Well,
for.
and she said that she doesn't know, like, if the company like squeezed it in on that last quote and nobody caught it, and like, so like they bought it and didn't know they bought it, or like if they were just like, oh, maybe we upcharged a little too much, let's ship the baby.
Right.
Like literally, that nobody seems to know exactly where the baby came from, but so now they have a pediatric one. So some of the stuff that we discussed in lecture today, now we're going to do, actually, complete. Again, that's something that's still on the national test, so it is something that I do have to teach you, even though clinically you probably will not be using it. Again, when you go to fill out your checkoff sheet, and you need to know the bony prominences of concern, they are on page 86 in your textbook. So that you don't miss any of them. Areas of risk of contracture. When we go over these positions, that's going to be, so think about, the first one is supine. So if your patient is in supine for too long, what tensile structures, what muscles, tendons, and ligaments are at risk for getting a contracture if all they do is lay supine?
back muscles?
Usually wrist,
supines are too long.
This is a show the back, it's a cheap.
Well, I mean, and if you think about the, positioning, there's going to be a pillow under the head with a C-spine in neutral. So this is the top of page 85. Pillow under the head with the C-spine in neutral. Support under the popliteal spaces to decrease lumbar lordosis. Pillow under the calves to relieve pressure on the calcaneus. Support under the elbows to relieve pressure on the bony prominences. If available, have the person's feet on a footboard for proper positioning. A hand roll made from a washcloth and a trochanter roll made from a rolled towel or foam may be used if paralysis or muscle weakness is apparent to keep the legs in neutral alignment. So that is a proper supine positioning. So, knowing that's how we're going to place the patient. Now, what structures are at risk for contracture?
Hips. Flexors.
Pardon?
Hip flexors.
Hip flexors is one. What'd you say, Natasha? Well, that would be at risk for pressure areas.
Oh, okay.
Right now, we're talking about, this column. So contractures, we're talking about, like muscles that are going to be at risk for contracting, meaning that they will get stuck in that position.
Elbow flexion.
Quadriceps? Cause it's,
Would it be the quadricep?
I guess it is.
No.
That would be the hamstring.
Where did it say the pillows were?
Underneath the back of the neck,
So what's gonna be short?
all the hamstrings would be.
Would the lumbar spine be?
Generally that stuff doesn't really get contracted. I mean, it can, but there's so many muscles involved that generally when we talk about contractures, it's a singular muscle or two.
Gastronomic, the calf.
Yeah, the gastroc can get short, gastroc and or soleus. So they're gonna get like a plantar flexion contracture. They can get a hamstring contracture. Well, generally, you're gonna have there will be a pillow for the cervical, but then you gotta think when they settle down into that bed, that there's not really as much, they're not gonna really maintain that cervical lordosis as much as necessarily to, cause that. So it's mainly the hip flexors, the hamstrings, and then the plantar flexions, so the gastroc and the soleus.
Nothing but. Nothing on your back because there's more pressure because it's elevated around it.
Yeah.
The back and back.
Right, but we're going by this description.
When you say hip flexors, are you talking about the iliopsoas or anything that results in hip flexion?
Well, all of those structures are gonna get short
Okay.
because you've got a pillow under the knees in the popliteal space, right? So this is just gonna automatically be bent. So they're never going to be, even when you take the pillow out, they're never going to be in extension.
Okay.
So hip flexors is a big one. We usually just say hip flexor or hip flexion contracture. So. Okay, so for prone, we're gonna place a small pillow under the head. a pillow under the lower abdomen to decrease lordosis, a towel roll or pillow / bolster under the ankles to relieve stress on the hamstrings, decrease pressure on the feet and permit the pelvis and lumbar spine to stay relaxed. Put a rolled towel under the anterior shoulders to retract and adduct the scapula. Note, the prone position may not be tolerated for a lengthy time or not at all if the patient has respiratory problems. So, there's really not a ton of risk for areas of contracture in prone patients because they have a tendency to not stay that way. So, but you have patients that go to bed on their back with those pillows under their knees, and that's their position of comfort, and there's a very real risk for those hip flexors, hamstrings, and plantar flexors.
When I lay on my stomach, I end up having to switch because of my neck.
Mm-hmm.
I mean,
Right.
because I don't have that much movement.
Yeah, I was gonna
anyway.
say, you're
I mean, I-
lacking a lot of movement, yeah. So, I mean, eventually, but we're talking about sick patients. We're not talking about us as
Well, that's just what I
normal,
go by the nose.
well humans. Because when we get uncomfortable, we're going to move. When they get uncomfortable, they can't. Some of them can, some of them can't. So, we're talking about the patients that necessarily cannot move on their own. And where are they going to be at risk for a contracture? Like I said, we're teaching you the prone position because it's still on the board and, we still test it out in here because it's still on the list. Clinically, you're probably not going to use it. And even the book notes that a lot of people can't tolerate it and they're probably not gonna spend their full 2 hours in that position. So, but remember, don't forget it as a treatment tool. Don't forget to include it into your physical therapy treatments. It might not be a viable position to leave someone in, but that doesn't mean that you shouldn't be using it for some of your patients with horrible posture. Belly. Tummy time!
Could you add, like, if they were at an outpatient clinic and you told them to lay prone, could you tell them to do, like, movements? Would that help with their posture? Like, if they were to do, like, this while they were laying? Or this?
You could, but even, and again, I know it's hard because y'all have never seen patients. The patients that I'm talking about that this would benefit, that would be way outside of their capabilities. Way. If you could get them in a prone position with about 3 pillows under their chest, you would have gotten an enormous win
So
in a
this is,
Parkinson's patient.
so this is used mainly in like acute stage, where you can't really do AROM or anything.
This, yes, yes. But if we're using prone as a treatment, it could be a Parkinson's patient that's fully mobile, that's coming to you for treatment, but that's the best way to work on their posture issues. But still, if we can get him in that position, the likelihood that he could do anything with his upper extremities would be probably 0.5%.
Okay.
So, doesn't mean that prone is completely out the window, we just don't use it much as a positioning tool per se, because so few people tolerate it. So, but you still,
But, you mean for extended length of time? Because so many of the exercises, you need to be prone.
yes, yeah, exercises, treatments, modalities, you'll have to have people in prone to access anything on the posterior side. But
Or even,
so, but as a positioning tool that we're going to put somebody in to relieve pressure for 2 hours at a time, it's not a very viable option for that.
Can you combine that time to reduce the amount of time that they are prone? So if you know that you're gonna be prone for exercises, can you do that last and say, all right, now you're gonna stay in
I mean,
this
you
position?
can, I mean, it's,
Plan
but again, patients that need positioning are very likely not going to be doing prone exercises with you. And I know it's hard to wrap your head around, cause you haven't physically seen these people yet to know the differences. So, we're getting a little outside of what we need to be talking about right now. I just don't want you to think that prone is off the table. I want you to understand prone as treatment options and prone as positioning. Okay? Alright. So sideline, so we are talking full on sideline, like in picture C on page 84. Place a pillow under the head, but not under the lowermost shoulder. So it's just gonna go under the head, but not under the shoulder. Under the uppermost arm to keep the chest open. So there's gonna be a pillow there as well. The legs and knees are flexed with a pillow between the legs, and the upper lower extremity slightly forward. A wedge or pillow may be wedged at the back and or chest to assist in comfort and alignment, and a pillow or towel roll can be used under the lowermost lower extremity just above the lateral malleolus. So, if we're talking about, this is somebody's position of comfort. So this is how they go to bed and they stay all the time. Nursing puts them in this position and then they refuse to be moved. Just like our supine patient, because that happens. We can't force them to be positioned. We can say, you're going to get a bed sore. We can say, you can't lay this way all the time because you're gonna get stuck in this position. We can give them all the education possible, but if they don't wanna move, we can't make them move. And people that are bedbound have a tendency to not wanna move once they get comfortable. Because it hurts other ways. Or the process of getting them from point A to point B hurts. Sometimes the point B doesn't hurt once we get them there, but the process of getting them from point A to point B causes them pain. So, that's a whole nother discussion. But, so you have to do your best to make sure that you make them understand why we're doing what we're doing. And that's where you're gonna pull out the skin, the subcutaneous tissues, the circulation, all the things that we talked about this morning. That's the education that you're going to give them as fuel as to why we're doing the position changes. So, as far as, this is somebody, like I said, the bony prominences are, actually, they're on the bottom of page 85 and in the chart on the top of 86. So, as far as areas for risk of contracture, in picture C, we have many of the same ones that were for our supine patient, correct?
Yes.
Add the arm,
Yes, you would probably add what?
the one, the left arm in this picture.
Probably add an elbow,
Lateral,
Epicondyle?
yeah, elbow,
Lateral epicondyle?
shoulder.
yeah, elbow what? Which muscle is shortening?
Bicep.
Yeah, so flexion. We have a tendency to call contractures we can say they're getting a bicep contracture, but because it's not just the muscle that's getting cemented, right? It's also the ligaments and or tendons. So, although that's not a wrong statement to say the biceps getting contracted, we normally say it's an elbow flexion contracture.
Would you worry about the neck at all in C?
Not necessarily. Again, the spine is such a, I mean, not that it can't get stuck,
Yeah.
but they're mostly going to be in a neutral position forward. It's not like it's constantly turned because the whole body is turned. So,
So, what about like the hip and the knee as well?
they're gonna be the
Yeah,
same
they're
as the
also- okay,
supine.
okay.
And the ankle as well. Because in that position, those feet are just gonna fall down to gravity.
How about the upper shoulder too, because it's constantly.
Yeah, I mean, they're gonna be at risk for frozen shoulder. I mean, not necessarily, I mean, but are they using that arm to feed themselves, to do anything, you know, I don't know. So, and then in sitting, we're talking about, it could be sitting anywhere, but, for this class purposes, we focus on, a patient sitting in a wheelchair. Because if you go to a skilled nursing facility, which all of you will either go to a hospital or a skilled nursing facility. I mean, the program is designed that way. You will wind up in an inpatient setting where patients stay there. If you wind up in a skilled nursing facility, if a patient is able, that patient is in a wheelchair and up and pretty much stays in that wheelchair most of the day. If you wind up at a place like Encompass Health, that person has gotten up in the morning and they stay in that wheelchair pretty much till after supper. The program is designed that way. They are there for intense therapy. They do not want them in the bed. They should not be laying. They want them up, moving as much as possible. Not so much in a hospital. But we do get our patients up to chairs in the hospital. Early mobilization is a huge thing. And me and an OT and the director of the Open Heart ICU made a early mobilization program for the OHICU, which was the Open Heart Intensive Care Unit, and laid out an entire program for early mobilization to get these patients out of that bed at the very first moment that it was capable, possible, and safe. Because we know that's what they need. So they're up. They're sitting in chairs, in wheelchairs. What we're gonna talk about for bony prominences and contractures is we're talking wheelchairs. Because so many of your patients in skilled nursing facilities in particular, and then like in an Encompass type setting, of course, they're gonna have a lot of therapy thrown in with that. So it's not as worrisome in an Encompass type setting because they're gonna have 3 hours of therapy to go with their seated time in the wheelchair.
And OT,
Huh?
they do like their PT and OT kind of together, like they switch off.
Yeah, I mean, but they get 3 hours of therapy
Yeah.
a day. In a skilled nursing facility, you have a mama that does not wanna go to bed because she doesn't wanna be in her room because she's nosy and she needs to see what's going on all day long. So she wants somebody to put her in that chair at breakfast and she's still roaming around the home at 11 o'clock at night. But she can't stand on her own because she's a fall risk, which means that she's in that chair 12 hours a day or more. She's gonna be at risk for breakdown from positioning and contractures because of positioning. Because a lot of them get in those little wheelchairs and then they use their feet to scoot themselves around all day long. They just walk that chair around with their heels. Zoom everywhere. They're everywhere. You turn around, they're under your feet. They're in the activities room, they're in the dining room, they're in somebody else's room, they're everywhere. They don't want to confine them to one area. That's their home. That's where they live. These long-term residents, that's home. So, having said that, we're focusing on, the areas of a wheelchair in particular. So that's when you look at the picture on 85, and then when you look at the chart on 86, it does focus, a little bit on the, wheelchair, especially the picture on 85, because it's gonna show you where the scapula, would hit and that type of thing, where you have to worry about, the size of the wheelchair, which we'll learn later in this lab. So, but, so the bony prominences that are at risk. So, if we have somebody sitting in a chair for a long period of time, where are our contractures going to happen?
Hip flexors,
Hip flexors,
knee flexors,
What flexors?
elbow flexors.
hip flexors, hamstrings, so knee flexors.
Hamstring?
Dorsiflexors.
Hmm.
Well, if they're moving, what
Dorsiflexors?
it calls them, if they're being pushed.
Well, it depends on the footwear, or
If they have
do they
the
have
things-
foot plates, do they not have foot plates? They may be at risk for a plantar flexion contracture, so they may have that drop footish look. If the wheelchair fits, if it doesn't fit, if they use their feet to power themselves or not, so, I mean, that's a possibility. If they're on the footrest and the footrests don't fit right and they just kind of push off the ends, so that's a possibility. They're all going to have the hip and the knee flexors.
How about, wouldn't the glutes kind of fall asleep?
We're talking about contractures specifically right now.
Alright, well,
What about the
this isn't
forearms?
a contractor, but I would think if they only use their feet to get around, their shoulders would get distracted, so wouldn't that shorten something up?
It would be more of, if they're only using their feet and their arms are on the armrest all the time, what would be contracted?
Well, definitely the wrist flexors, but,
So elbows again. And I mean, you could look at a possible frozen shoulder, but we're not really looking at anything, you know, particularly in the shoulders that's being shortened.
I think it could be lengthened.
So when you think contractures, you have to think that there is a muscle being shortened and staying in that shortened position all the time. That's a contracture. So that's why the shoulders don't come into play in a lot of these situations, because it's kind of in a neutral position, and we may get adhesive capsulitis from not moving them, but it's not a contracture.
And they'll never set someone in a chair that's not, doesn't fit right.
I mean, ideally, no.
What if they are like a stroke patient or something, and they have like limited mobility and they're in like a power chair? At that point, would,
Power
you
chair's
see
gonna be,
different types of
power chair's
contractions?
gonna be tricked out, they're gonna have specialty everything, so, yeah. If somebody's in a power chair, that it's gonna have measured for them, they're going to have either an arm trough or a table to put their arm on that's attached. That's not gonna be a concern. So you have the bony prominences from the book. We just discussed the areas of contracture.
It was
So-
just a hip and the hamstring, right?
Pardon?
The hip and the hamstrings.
Yeah, but you
And then possibility of like
the dorsiflexion contracture. So, that's why I said you need to get in the habit of calling them by what's being shortened. So hip flexion contracture, knee flexion contracture, dorsiflexion contracture. Get in the habit. I mean, if you tell me that it's the bicep is contracted, but for clinical work, and again, if we practice it the way you perform it, then you don't have to go back and fix it later. So, if you start thinking about it now in those terms as you're learning these terms, then that's just the way you're gonna know it. So, you obviously have to think about which muscle it is. You have to know which muscle it is and which action it does. But it's the one that's short. It's always the one that's short that is contracted. And if it's not shortened, then we can't call it a contracture, even if the motion is limited. That makes sense to everybody? Okay. So, we are going to practice these 4 and how to decrease the pressure in the areas of these 4.
For this checkoff, do you want one of each?
Okay, so, going by the, description in the book, there at the top of page 85, supine is we're gonna place a pillow under the head with the C-spine in neutral. So, we are going to start, and then also, when we look at the things that we're looking for on the bony prominences, the occipital tuberosity, so we've decreased that with just the pillow. I mean, that's gonna decrease it a little bit. The spine of the scapula. So if we leave the pillow in this position in particularly, the spine of that scapula is gonna be pretty much pressing right down on the bed. So usually what I have a tendency to do is I will lower that pillow just a little bit, put back up, to where the spine of the scapula are just ever so slightly on the edge of that pillow. Again, it's not about making sure there's pillows under everything, because that doesn't solve anything either, because then everything's on the same level again. So all the pressure is on the same level again. It's about varying the pressure and offsetting the pressure. That makes sense? So, if I do this and just put that right about the spine, then I've ramped that pressure just a little bit. So now the spine of the scapula isn't quite as at risk as it was before. The vertebral spinous processes and the sacrum. So I'm going to take care of that with I usually try to find a flat pillow, and this is not that quarter turn that I'm talking about. This is just for supine positioning. This is not in the description. It doesn't say anything about a pillow under the hip. This is best practice, because if we are protecting everything in the table for supine, that's where I'm going with this, okay? So, we need to protect the contractures, we need to protect the bony prominences. So, because we're usually talking about somebody that literally cannot move themselves if they need to. So I usually try to find the kind of the thinnest pillow I can, because again, this is not about padding the person. This is just about offsetting them enough to change the pressure. So normally what I will do is I will tuck just enough under, well, just a little higher. So Jeremiah's waist is right here. And so I want a good space. This is not about patting him from head to toe. So there's a good space between the pillows. So I'm offsetting by turning him just ever so slightly, cause when he lays back, he's still going to be supine. But that's gonna raise most of the vertebral bodies, not off the bed, but it's gonna change the pressure. Also, it's gonna change the pressure on the sacrum. I'm not going far enough to go to pull the sacrum off the bed. Go ahead and come back. Now, can you feel the difference? So, again, he's still supine. We're not necessarily quarter turn. That's not the object. And that pillow under his head might be the best one, but I'm not changing it. So you still want him to be in supine. That's still the object. But now I have changed the pressure on the sacrum and the vertebral spinous processes to make sure that for the next 2 hours, we've changed it. Did we put a little extra pressure right here?
Yeah.
Yes, but that's not as vulnerable as the sacrum and as those spinous processes of our little 50-pound ladies.
You don't wanna put it on both sides, cause now this side has
No, 'cause
more
that would
scapular
redirect it
pressure.
back on the sacrum.
Because then that puts it right back everywhere I just took it off from. Because in 2 hours, we're gonna change the pillow to the other side.
Or you're gonna keep them supine. Okay.
And then that's less movement for the patient and less work for the nurses. That makes sense to everybody? Okay, so now I've taken care of the head and the trunk. The upper extremity, you wanna worry about, now see on this side now, I have an extra pillow over here. So the upper extremity, the condyles, all that stuff, we're pretty much okay over here. I'm going to take a towel and probably quarter it somewhat, not necessarily a roll, because I want it to be a little fat. Just to give it that little bit of an uphill, so that he's draining back down. And then again, when it's time to do this again, everything is gonna shift over that direction. So we don't necessarily need to address the other side of the body until 2 hours from now. And the olecranon process also is, we're not full on, we can actually bring this out a little bit into abduction, which does put a little bit more pressure to the medial, so you can just kind of play with the elbow a little bit and figure out the best position, because you're going to be talking to your patient during this as well. You're not just going to be doing, I'm out, you know. Okay, does that feel good?
That's great.
You know, and if they say, oh, that, and you say, okay, well, let me readjust this a little bit, or my arm can't stay in this position the whole time. I mean, it might be clinically exactly what's on the paper,
I
but
said 2 hours.
if it's not comfortable in that position for your patient, then you may need to, I mean, they may like the elbow more here than they do here. They may have an old shoulder injury that they don't really like it out into abduction so much. So you're gonna have to talk to them too, as you are working with them. Now
I have
the,
a
yeah.
question. I mean, even in the hospital,
uh-huh,
maybe it's just me, but I sleep better without the pillow, because otherwise I feel like my neck is forced up.
mm-hmm. So if you have a patient that has that issue,
It's not the contractions.
make them a cervical roll.
And keep the pillow?
Mm-hmm. Because the cervical roll should now make the head go back.
Yeah. Plus that way you can breathe better, instead of like that.
But I'm still protecting the spines of the scapula and offsetting the pressure on the occiput. Lower extremity, we're worried about the calcaneus, the greater trochanter, which on this side is protected. We'll get to the calcaneus in just a second. The head of the fibula, also we're gonna address that, but by elevating that one side just very, very slightly, we take care of all that on that one side. Also, by using this method, we're also keeping this one side hip from kind of rotating outward. So we talked about we want neutral hip alignment, and there's another technique I'll tell you, because sometimes even when that hip is super weak, it can still flop out this way, and I'll show you how to correct that. But a lot of times, just giving them that little bit of shift in one direction will be enough to kind of help keep that one side in neutral, and then again, when you have that change to the other side, we'll keep that side in neutral for the next time period. So, kind of flipping back over to the other side, in order to keep the lumbar spine happy, we can use bolsters. We've got, this one's not gonna work for under the knee, and this one might be too much. So you can, just depending on what your patient is comfortable with, if that works for them, if that's too much, you can use a doubled up pillow. The downfall to the bolster is what? What have I just done by using the bolster? I increased what?
Increase more.
I increased the pressure on the posterior calcaneus. So, you can do that, but then you've got to use something else for the foot. So, that wouldn't be wrong. You could do that. I have a tendency to try to roll up a pillow right below the popliteal space. So now I've got a little bit of knee flexion, but not a lot. I don't have a great deal of hip flexion. I might not have any extension, but I don't have a great deal of hip flexion or a great deal of knee flexion. But did it relieve the lumbar?
It keeps me on that slant too still, cause before it felt like it just moved me more. Here it like turned it back this way.
So, that relieves the lumbar, and it's going to keep me in a little bit of knee flexion so they're more comfortable, but then it's decreasing that risk of a knee flexion contracture that you would get more with this. And it's, again, not keeping the heel, it's not floating the heel, but it doesn't give you the pressure that this gives, right? And it doesn't give you the pressure that just flush on the bed gives, right? Right. So, and if in this position, cause still sometimes that hip is just determined to flop out here when they're super weak. So you can use a bolster underneath the outside of that pillow to keep that hip in whatever variance of neutral that you need to keep it in, and neutral relative to the pelvis. Make sense? And then so everything that you just did, or we just did on Jeremiah's left side, in 2 hours, it would be done to the right side.
So
And then he would be turned to a full side lying on one side and a full side lying on the other side.
So at what point do we need to do this? Cause this to me is what I did as a nurse's aide when I was 15 in the geriatric ward.
Yeah.
when do we as PTAs need to do this? After treatment?
Yes.
Putting them back in
Yes.
bed?
When we bring them back from, when we get them out of bed and we take them to treatment and we bring them back, you don't ever just put them back to bed and leave them in a position to where, okay, well, therapy brought them back, so they're good, I don't have to check on them for 2 hours. And then the nurses will see how you left them and then position them accordingly the next time. Make sense? Yeah. So no, this is not something that you're coming in the room doing every 2 hours. That is the nurses or nurses' aides or however the facility is set up. But you need to know how to position a patient once you're done treating them. So this would be supine. And then, the next variation of supine would be everything on the other side of this patient. So, and again, it wouldn't matter because if you're bringing that patient back from treatment, they've been up and they've been around, so it wouldn't matter which side you choose. Sometimes I'll ask the patient, which side do you want the pillow under? And just kinda go from there. So. Good enough? Okay. You guys wanna practice that one before we go on to the next one? Yeah, okay. Either way. And you can use the treatment tables, obviously,